this webinar is recorded. Welcome to this webinar, AI for Inclusive and Equitable Health Management in Africa, brought to you by the Africa Center for Inclusive Health Management. My name is Kanshukan Rajaratnam, or Kanshu for short. I'm the director of the School for Data Science and Computational Thinking at Stellenbosch University and a professor of operations research at the same institution. The school is a transdisciplinary space that works with all faculties and external stakeholders to solve the grand challenges facing the country and continent through transdisciplinary activities. I also want to take the opportunity to thank the director of the Africa Center for Inclusive Health Management, Dr. Munya Saruchera, who convened this webinar and sends his apology as he needed to be elsewhere at a short notice. Well, back to the topic. How AI can transform health systems across Africa is a question that we face all the time. There are multiple opportunities and challenges. Africa requires to transform its health systems to be more effective in order to result in optimal health outcomes. Health systems are typically mired by funding constraints, impacted by external factors, and human capacity needs. Artificial intelligence, or AI, brings us an opportunity to provide solutions to some of these problems. This, together with the youth dividend that we find ourselves in Africa, can accelerate solutions that we so desire. However, it also introduces new constraints, such as energy needed to run AI infrastructure, among many other constraints. But the opportunities are greater than the downside of AI. There's, of course, issues like AI ethics and data ethics in the context of in our context here in Africa. We have three insightful presentations today. Each presenter will present approximately 15 minutes. I will introduce each presenter as they share their presentation. We will take Q&A at the end of all three presentations. If you have any questions, please write it in the chat room. We hope to have discussions to advance our goals for better health outcomes in Africa. Let's explore collaborations, funding, and opportunities. I think this is a great moment to think about how we can all work together to improve outcomes here in Africa. Let me introduce Dr. Tafadzwa Dzinamarira. Please, can you share your presentation as I introduce you? He is the country director for Zambia at the International Center for AIDS Care and Treatment Program. He's a public health expert with a solid clinical and epidemiological research background. He has over 7 years of experience providing technical support for public health systems and clinical laboratories, strengthening the management of HIV/AIDS programs. Dr. Dzinamarira has expertise in providing technical leadership in developing, planning, and implementing national household-based biomarker surveys. He holds a Master's of Science in HIV/AIDS Management, a Master of Public Health, specializing in disease prevention and control, and a Doctor of Philosophy in Public Health Medicine. Before this role, Dr. Dzinamarira was the country director for ICAP in Zimbabwe. Before that, he was the regional laboratory technical advisor for a PR project, where he successfully supported the implementation of national HIV impact assessment surveys in Namibia, Rwanda, Haiti, Eswatini, Lesotho, Malawi, Mozambique, Uganda, Tanzania, and Zimbabwe. Before joining ICAP, Dr. Dzinamarira worked for the University of Zimbabwe Department of Medicine on a prospective operations research series aimed at decreasing mortality by initiating antiretroviral therapy in Africa through early detection and prevention of cryptococcal disease in Zimbabwe. Over to you, Professor.
Thank you so much, Prof. Please confirm that I'm audible.
You are audible, but on your slide I can see your slide now. Thank you.
All right. Okay. Thank you. So I'll just advance the slides. All right. Thank you so much for the opportunity. Good morning, good afternoon, and good evening, everyone. Thank you for joining us today. It's a real pleasure to be here with you today as we explore a topic that is at the intersection of two powerful forces that are shaping our future, so artificial intelligence as well as healthcare access in Africa. As introduced, my name is Dr. Tafadzwa Dzinamarira. I support the Africa Center for Inclusive Health Care Management as an extraordinary senior lecturer, and I also am the country director for ICAP at Columbia University in Zambia. So this is just to get us started. Being the first presenter, I'll share the outline for our talk today. Our slides are interconnected. We'll be following this outline that I've put in front of you. Really, when we talk about inclusive health management, we are talking about a vision where everyone, regardless of where they live, their gender, language, income, ability, everyone really has access to quality healthcare, and this is a challenge across the globe. But in Africa, we see that it is particularly urgent, as described by the moderator. So in Africa, we do face a dual reality of under-resourced health systems, which is evidenced by a shortage of doctors, fragile supply chains, high burden of disease, and at the same time, we are seeing rapid digital transformation. So this is your, for example, mobile penetration, fintech, digital health startups. All these are growing at incredible speed across the continent. So basically, our talk today, we are saying AI, if applied thoughtfully, could act as an equalizer, but if we are not careful, it could also widen the gap between the connected and the disconnected, between those who are represented in the data and those who are, for lack of a better word, invisible. So today, this is the outline of our talk. It will be two-part. We'll talk about AI for equity in health service delivery, and then we'll also continue realizing that the real opportunity lies in local innovation, and we want to avoid AI being just another one of those imported technologies. We would need to talk about opportunities for Africa-led innovation. So I'll set the context. I'll be framing the talk, why inclusive health management matters in Africa. My colleague, Professor Elliot Mbunge, will come in to talk about AI for equity in service delivery. And finally, Dr. Valamar will come in to talk about opportunities for Africa-led innovation. But before we dive into the application, let's start off by defining some key terms so that we are all on the same page. We understand the audience is at varied levels of understanding of AI, so it's important that we start by having these definitions out of the way. So when we talk about artificial intelligence or AI, we mean computer systems, just in plain language, computer systems that can perform tasks that we normally associate with human intelligence, things like recognizing speech, identifying patterns, or making decisions. So machines performing these tasks that normally require human intelligence. To put it simply, that would be a definition for AI. And a major branch of AI is machine learning. And this is when we don't just program the computers with fixed rules, but instead we feed it large amounts of data and let it learn patterns from the data. So teaching computers to learn from the data, that is what we'll be referring to when we mention machine learning throughout this talk. And at the core of many AI systems is prediction. So this is when the machine takes what it has learned from past examples that would have fed into it and uses it to forecast something new, like, for example, predicting which patients might be at higher risk of treatment failure, for example. So prediction is going to come up multiple times throughout our talk today, and it simply means using past data to forecast future outcomes. And these predictions are powered by what we call algorithms. So you hear the term algorithms again frequently throughout the talk today. And really these, you can think of them as step-by-step instructions that the computer follows to process data and make decisions. And these concepts are very important for us to keep in mind. AI, ML, prediction, algorithms. We need to keep them in mind as we are going to be unpacking how AI can improve health equity in our African context. Just a few more definitions. All right, just a few more definitions. So AI is only as good as the data that it is trained on. So data, we're going to be mentioning a lot about data. So these are things like patient records, laboratory results, medical images, and this is the raw material that we use with AI. And when data is collected at a very large scale, sometimes from millions of patients or across entire countries, we call this big data. So very large complex data sets, often from multiple sources. That's what we'll be referring to as big data. And then to build AI models, we use a process of training and testing. So training and testing, we're going to be talking about that as well. Training is like school for the machine. We give it past data and correct answers so that it can learn the patterns, and then we test it on new data to see if it can make accurate predictions of its own. So those that would be a simple definition of training and testing. And then finally, a very critical concept that will come up in our talk today is bias. So if the data we train the system on doesn't represent everyone, for example, if most of the data comes from urban hospitals, but not rural clinics, then AI may give poor results for rural patients. This is one of the biggest risks that we must guard against to ensure that AI is truly inclusive. So with those definitions, I'll move on to the next slide, where really, as I mentioned in my introductory remarks, I'm trying to set the stage, I'm trying to set the context and introduce you to Africa's dual challenge, where we are looking at under-resourced health systems that need to be strengthened, but also competing with the rapid digital transformation that we are seeing in our context. And as I mentioned earlier, AI has the potential to come in and be a potential equalizer, make life easier for us in terms of healthcare service delivery, but it also risks widening the disparities that we see existing within our context. And for the next slides, I'm going to talk a little bit more about the current inequities in the Africa health system. For example, you look at rural and urban access to healthcare, limited access to health professional and trained healthcare workers, gaps in diagnostics, very poor indicators to do with maternal and child health, and the emergence of non-communicable diseases that we are having to manage, in addition to the historical infectious diseases that were a public health problem in our setting. So let's look at how healthcare inequities already shape outcomes in Africa. And this is important for inclusive health management. So first, I give you just a few examples in the interest of time. If you look at health worker density, it's extremely low in many countries. On average, we see about 1.5 physicians, nurses, and midwives serving a population of 1,000, which is far below what is needed for universal coverage. The rural populations, we see that rural populations tend to be the most underserved. In many places, up to 2/3 of people in rural and remote areas do not have adequate access to essential health services. And according to the International Labour Organization, only 23% of the global health workforce is serving rural areas, but we know that nearly half, about 50% of the world, is living in these communities. So that is another glaring statistic that we can refer to here. So basically what we are saying here is these gaps are not just numbers. They translate into higher, for example, maternal and child mortality. They translate into delayed diagnosis, longer travel times to clinics, missed opportunities for preventative care, which end up being quite costly for the countries that are already facing economic challenges within our context. So as we talk about AI, this is the context in which we ask, can technology help close these divides rather than widening them? It's very important that we look at that today. And then on the digital side, we are seeing that Africa is making real progress, but gaps continue to persist. Currently, the latest data I was able to pull, it showed that estimates were put at around 36 to 43% for internet penetration across the continent. This is according to data from the World Bank, which is quite encouraging. And again, the World Bank reports that the broadband access has improved. We see an average download speed in 2019 was 2.7 megabytes per second, but as of 2022, it had jumped up to 8 megabytes per second within our continent, and that's quite encouraging. Also encouraging, surveys have shown that affordability is also becoming less of a barrier. In many African countries, the cost of 1 gigabyte of broadband, of data, it dropped from about 10.5% of the monthly GNI per capita in 2019 to around 5% of the monthly GNI per capita in 2021. So these are all quite encouraging steps that we are seeing being taken by countries within Africa to make sure that we are also included in the part of the digital transformation. However, we still see some important and notable gaps. I just singled out an example here of Zambia, but there are many others. In Zambia, we have a study that was conducted in early 2025, which revealed that about 33% of the population was using internet in early 2025, meaning about 2/3 of the people are still offline, right? 67% are still offline, despite nearly everyone having a mobile phone connection. So there's still some gaps that need to be addressed. So these numbers show both opportunity as well as urgency. And as AI becomes more feasible, things like connectivity, speed, cost, rural versus urban access will basically shape who benefits and who is left behind. And we are talking about a context of inclusive healthcare management. So it's very important that we keep these in mind. All right, so just some reflections from my introductory talk. To understand the promise of AI, it was important that we ground ourselves in the problem, which we've discussed. And before I invite my colleagues to come in as well, I just want to summarize that across Africa, health systems remain uneven. Access is often determined by geography. I gave an example of the urban and rural disparity, with urban residents having 10 times more likely to see a doctor than someone in a rural village. And we also face severe shortages of health workers. According to the World Health Organization, Africa carries about 25% of the global disease burden, but it's only about 3% of the global workforce, which is quite disturbing. And when it comes to health outcomes, whether your maternal mortality, child mortality, or access to cancer diagnostics, the gaps are glaring. So the question becomes, can AI help us bridge these divides, not just for the wealthy and connected, but for the millions who are currently left behind? So, Chair, I'm going to pause here and invite you to call upon Dr. Elliot Mbunge to dive into the next sections of the presentation.
Thank you so much. That was great. So I'm going to now introduce you Professor Elliot Mbunge, who will then do the next presentation. Professor Elliot is at the Department of Applied Information Systems at University of Johannesburg. He is a mentor, researcher, and innovator specializing in IT, holding a PhD from Durban University of Technology in South Africa. He supervises and lectures both undergraduate and postgraduate students and guiding research in areas such as applied machine learning, information technology, information systems, and healthcare optimization. His research focuses on health informatics, information technology, machine learning, digital technologies, and ICT for development. Professor Mbunge has been collaborating with other scholars on international research initiatives funded by the renowned organizations such as the Royal Academy of Engineering and the United Nations Development Programme, amongst others. He continues to drive technological advancements and sustainable digital transformation for the betterment of societies through research, education, capacity building, and community engagement. Over to you, Professor.
Thank you so much, Prof. Rajaratnam, and to also Dr. Tafadzwa Dzinamarira. So I just want to confirm if I'm audible enough.
You are. Thank you.
Okay, thank you so much. Okay, greetings to all our audience across the globe. So I just want to extend this presentation from where Dr. Tafadzwa left. He gave us a very brief, good introduction about AI and health management. So I'm going to take you through the next slides and then present on how AI can improve equity in healthcare service delivery, especially in Africa. So can we move on to the next slide? Okay, it's fine. Thank you so much. So move on to why equity is important in health service in Africa. So like what Mr. Dzinamarira highlighted, that we're talking about health equity, we are simply saying everyone should have access to quality care, regardless of probably language, gender, religion, and sometimes socioeconomic status and disabilities, and all other existing barriers that might affect access. But in most African countries, we have noticed some disparities in access to care, and sometimes a lack of access to specialists, probably because of some existing challenges, could be infrastructure, and these challenges they then cause a lot of equities in education. And some of these challenges are also exacerbated by existing impediments, which then affect different population groups, especially in rural areas and hard to reach communities or population groups, especially women and some people with disabilities and those who are coming from low-income groups or individuals. So, like he indicated, that AI is coming as a tool, if we effectively use it ethically and responsibly, that can bridge these existing inequalities or challenges that we face, especially in Africa. And then when we do this, we can actually optimize healthcare service delivery and also bring about opportunities that might benefit everyone, especially those that are living in resource-constrained areas where access to care is a big challenge, and also access to a healthcare infrastructure is also a big challenge. So we want to bring in AI, and when we do this, we should also take note of those that are living in resource-constrained areas so that we don't widen the existing gap in accessing care. So now let's move on to the next slide, where we talk about the ways in which AI can address some of the health inequalities that we're currently facing, especially in Africa. So we understand that AI plays an important role in bridging some of these inequalities. But now the question that we have to ask ourselves is how best can we ethically use existing AI tools? It could be algorithms, it could be systems, or models that we have turned into executable application to do different functional activities to improve healthcare in Africa. So as we know, during COVID-19, we just want to give that one as a point of reference. We have noticed an increase the importance of using AI, especially in Africa and especially in some of our resource-constrained areas. So we can actually improve and enhance the use of AI in diagnostic and also for early detection. And when I'm talking about a diagnostic, now these days we have AI-powered imaging tools, and some of these tools are used now to detect the most prominent diseases that are affecting our communities in Africa. For example, tuberculosis. We have also cervical cancer, which is also another challenge, and pneumonia. And also in Africa, we experience a lot of malaria, and are contributing significantly as per World Health Organization recent statistics. So we can actually use these powered imaging tools to improve health outcomes and also to enable early diagnosis of these diseases. So we have some examples where some of these AI-powered imaging tools have been successfully used. For instance, in South Africa, we have what is called the CAD for TB, the computer-aided diagnosis for TB, and it is used as a screening application that uses AI to interpret chest X-rays, and is being used in different provinces, including KwaZulu-Natal and Western Cape. And also we have another example that successfully implemented in Tanzania, where AI is used as an imaging tool in Tanzania, where they use AI visual inspection with acetic acid tools for testing and screening cervical cancer in low resource areas. That particular tool has been used successfully and is using positive results, which means that there are some tremendous opportunities that we can tap into and apply AI algorithms and convert them into executable applications and deploy them in our resource-constrained areas. And then we also have another very good example or reference where we have used AI to come up with imaging tools in Ethiopia and Zambia and Ghana. They are using AI for in malaria microscope. And this tool is being piloted to identify different malaria parasites in blood smears. And we have some companies that are playing an important role, like Naum Lab playing an important role to integrate smear preparation, staining, and also imaging using AI-supported detection tools in portable devices. These are some of the good opportunities and piloted applications that are bringing in positive outcomes in our African context or in our healthcare service delivery. And then now, because of different devices having different computational capacity or strength, and these days we are talking about our very good high-powered machines, and also have very good portable devices such as smartphones, tablets. So now we are witnessing a sudden increase in mobile-based screening tools. Some of these applications, they are used by different healthcare professionals in different settings to detect the different diseases and also diagnosing. For instance, we also have different applications. In Kenya, they use what we call, I really like the peak vision, not because I'm advertising for them, but why I like it is because the application is used to examine eye in rural communities with the vision, screening, and referral. And the one thing that I also liked about the application is that it is being used by healthcare professional, the teachers. They are also using the application. Non-specialists, they are also using the application to perform vision tests. And the application connects the individual to treatments. And when they do that, there is evidence from the literature that they are reducing costs and making service more accessible and available to everyone, especially those that are in the rural areas, which is good because we're trying to bridge inequalities and make sure that we also work towards ensuring equity. So what the application does, it is once they detect, and it is you running on a mobile application, right, and they've incorporated decision support algorithms, and from the algorithms, they can also provide some decision-making process and some referral using SMS reminders and also real-time reporting. This is why I say I like the application, because everyone in the rural area, if they have a smartphone, if they are connected to the internet, they can simply install the application, and the application has got that capacity to analyze and then make some reminders and recommendations. So this is a good example of the mobile-based screening tools that have integrated artificial intelligence algorithms into healthcare. And in Nigeria, there is another interesting application, 𝗵𝗏 app. And the 𝗵𝗏 app, they use AI, especially machine learning algorithms, to analyze the baby cries. If the baby has got asphyxia, then they'll make some recommendations. So it uses acoustic features such as pitch and frequency to provide a quick non-invasive assessment for those kind of conditions, such as a baby asphyxia. And there is actually good recommendations and also results coming from the application. So some of the few applications and successful deployment of AI-based mobile applications in different healthcare settings. And of course, Rwanda is also playing a very important role in early diagnosis and detection. They've introduced different application in maternal health, and now recently it was all over the news that they are introducing AI to provide virtual hospitals and through the use of AI and robots. And when they do this, they're also trying to improve access to care and to reduce the burden on healthcare professionals. And so some of these are very good areas that we can explore the algorithms. And recently now we have noticed an increase in the development and deployment of child support. So which is another example where we can apply AI to address inequalities in Africa, especially in healthcare service delivery. So when we apply this generative AI and develop chatbots to help and assist healthcare force. So we have noticed that some of these algorithms that are now used to develop chatbots to do what is called triage and also send reminders, and also to do some symptoms checkers. And they provide multilingual health education. We know that in Africa we have different languages and dialects, and these are our vernacular language. So these chatbots, they are now supporting healthcare for professionals in sending reminders, health education and promotion, and etc. And you also have very good examples where they are actually piloting some of these applications. For instance, recently in South Africa, we have what we call a Mom Connect. Mom Connect is what it started as a smartphone application that uses SMS. It was rolled in 2014. And since then, right, they celebrated the 10-year last year. And since then, they've been improving and then rolling this application in different areas. So Mom Connect, it provides maternal service, advice, and reminders in different languages. Now they've incorporated WhatsApp chatbot, and this is in different languages, including isiZulu and isiXhosa. So these are some of the good examples where we can actually apply and roll these applications at a national level or at a regional level and continental level. But like I said, we need to also check and understand the ethics part of it. And also, in Zimbabwe, there's also another application that is called Nyamukuta, a WhatsApp chatbot which is transforming maternal healthcare. And I know these days, different countries in Africa, they are moving towards incorporating chatbots, improving healthcare access and communication, and also making sure that they incorporate different languages in the chatbot. So these are some of the few examples that we can probably learn from and understand the importance of these AI tools that we can incorporate in delivering healthcare services in Africa. And recently, we also noticed that now we have what we call decision support systems. And AI now are guiding healthcare professionals, especially the community healthcare workers and the nurses, on treatment plans and some diagnosis. But like I said, there are some ethical issues or concern that should be carefully observed when we incorporate these the different AI algorithms or model in clinical decision to assist, or when we implement them into our workflow. There are some ethics and issues that should be carefully observed. But nevertheless, there are also some examples where we have countries like Tanzania. They've implemented what we call electronic tool to improve quality of healthcare. And this is a decision support system that is used by healthcare professionals. And they're piloting it, and it's yielding positive results. So these are some of the examples. Like I said, again, in Malawi, they are also doing the same. And also in Rwanda, they are also piloting different applications and algorithms to assist healthcare professionals, the clinicians, in making decisions. And then another important aspect, colleagues, that we can actually incorporate AI algorithms or models, be it supervised or unsupervised, is to use these models in resource optimization. So we can actually use this to predict, to do what we call predict analysis. And when we're talking about predict analysis, like I said, we want to give examples of our COVID and most of the diseases that we're currently facing in Africa, such as cholera and then Ebola, etc. And we can actually forecast the potential, the possibility of probably having cholera outbreak using past data and also current data, then applying machine learning algorithms or deep learning algorithms in line to predict potential outbreak and so forth. So these are some of the examples that we can actually use. So what happens is that in most countries, like now, if we look at the existing literature online from reputable database and outlets, there's a lot of information on the application of predictive analytics in healthcare, different countries and so forth. But now if you ask ourselves, why is it difficult now for us to actually deploy these models in a real healthcare setting so that we'll be in a position to make those predictions or forecasting? Yet we have algorithms that are able to analyze health data, real-time data coming from different data sources, right? It could be electronic health systems, it could be survey data, it could be social media data, it could be environmental data, including signals, and then forecast and see the potential of having epidemic spreading, and we analyze and then predict, probably using mobility data, and also probably detect the early signs of having an outbreak. Like I said, such as Ebola and COVID-19, why is it difficult for us to transform those modelings and implement them as an application and integrate with existing systems? And there are some ethical issues, like we said, but there's a lot that is being done underground in applying machine learning or deep learning algorithms to for predictive analytics. And in some cases, they are also using these models to do what we call intelligent resource allocation, colleagues. This is something very interesting. These days, we are actually seeing, after some modeling and so forth, there's a prioritization of intervention in some areas, and also mapping of interventions in some areas based on the results coming from our AI models. So policymakers, healthcare professionals, they are using these results to make key informed decisions, then prioritize the intervention of resources. When they do this, they also look at different geographical needs and the disease burden. And like I said, in some areas, they're actually implementing these models to do that. And we have examples from Kenya, the Living Good AI dashboard, which predicts the possibility of probably an incident that may occur. And then they use different models to guide the decision-making process. And in DRC, we have noticed that they are also using these models to determine whether there will be a vulnerability or so forth by analyzing data coming from different health data sources and also satellite imagery. So this is actually good because it assists the undeserved population groups and then health professionals to make those key informed decisions. And then another important aspect that we can actually look at and deploy our AI models in accessibility and inclusion. And remember, we are talking about equity. So issues around accessibility becomes paramount. So now we're talking about applying AI, people with a disability, and some people that are living in resource-constrained areas where we have low digital literacy. So when we're talking about incorporating AI to assist people with disabilities, we have witnessed a sudden increase of use of speech to text algorithms, and these are natural language processing tools that are used to develop different applications to assist people with disabilities, for probably people with some impairments and so forth. So this is actually good. And some, they actually convert an image to speech for the blind, and they are used now to develop health education and awareness programs using simple language. And now there's a combination of converting images into speech and also converting text to speech, right? And then incorporate our vernacular language to make sure that when we deploy an application, the people that we are targeting understand and then use the application effectively without having those kind of impairments when it comes to language. And in some instances, like I said, we are witnessing a sudden increase of this kind of application that ensures applications that ensure accessibility. In South Africa, we have those AI voice technologies that are now using isiZulu and different other languages. And these ones, they use, like I said, natural language processing algorithms to ensure that there is inclusive access to information, and now incorporated in chatbots. So these are another area that we can actually tap into and develop applications that suit our context in Africa. And also in Kenya, they are also developing different applications that are used to improve accessibility and also ensure inclusiveness. And most of these applications, they are using chatbots and so forth. So we have different assistive technological startups that are now piloting some of these applications. So it's a very good aspect that we should consider, and we're moving in the right direction, and we are actually witnessing a significant progress in this aspect. And then another one that we can actually explore is the use of telemedicine and in remote care. So we have seen some of the countries that are now moving towards this. We have Tunisia. They are implementing what we call 𝗵𝗵 AI teleconsultation, and which makes patients with the doctors and use AI-powered triage And this is very good because now we have an application that matches the patient need and with the right doctor. And in addition to that, they also do what we call triage. So this is actually good. Let's say you deploy an application, that kind of an application in deep rural areas, and let's say they have a smartphone and internet, and they'll be in a position to know that this kind of problem that I have, I'm going to see this particular doctor at a such and such time, and it gives them a triage and performs the triage. By doing so, we are improving health outcomes and also reduce the cost. So this is actually another good example of the application that is using AI teleconsultation. And in Zimbabwe these days, we've witnessed a sudden increase of AI-enabled telemedicine kiosks. We have some companies that are piloting telemedicine kiosk, and recently the same company piloted in Botswana, and it shows those cross-border initiatives. And these are some of the things that we need to look at in Africa, those cross-border AI initiatives. How best can we probably implement a successful initiative from one another country and another country so that we improve accessibility and also inclusion. And when we do that, we are also reducing the existing inequalities in our communities. So now we are moving to the next slide, which is talking about the risks that we might encounter as we do this. So we are saying, right, despite all those opportunities that we can tap into, right, we need to be very careful as we implement, as we apply different algorithms or models into applications and deploy them in different contexts. These are some of the risks that we need to be careful when we deploy those applications. So number one that we are always talking about as we develop AI-based applications is the algorithmic bias and data inequality. So when we're talking about algorithm bias, we are saying, right, we have witnessed different applications that are using AI or algorithms or models, but some of these applications, probably they were trained using data coming from non-African contexts. So the challenge with that is that when it's actually deployed in the actual environment, it might have bias. So how best can we retrain those algorithms using our African data sets so that when we deploy them, it may not underperform or bring bias in the actual healthcare settings. So because now when we also train them, even using our African data set, we should also make sure that the data set is coming from diverse population group, and so that we don't reinforce those existing racial gaps or ethnic or gender disparities in our healthcare access or outcomes. Because we know that if we have bias in data, it's going to lead in bias in decision, and it's also going to give us biased outcomes or results, and we risk making decision based on that, and we have a biased health outcomes. So all these must be carefully observed. And in some instances, we train our models using population-based survey data or so forth, and we know the limitations of population-based health survey data. So we need to carefully look at all those biases. It could be bias in data, it could be bias in algorithm, and so forth. So these are some of the challenges that we are currently facing, and we need to be careful when we train our algorithms. So number one, we said, let's train our algorithms using the data coming from African populations. And when you're using that particular data set, make sure that it covers all the population. And when we do what we call data pre-processing before deploying the model, we should be careful again on the steps that we take, because it might affect the performance of our models. And when it's like that, we risk making decisions based on the biased outcomes. Then another important aspect, colleagues, is the issue on data privacy, ownership, and consent. We understand that for us to have a very good AI-based application or system, that application must be trained. It must go through rigorous testing process, and also validation process. But now we have to ask ourselves, right, where do we get data to train these algorithms? Because for us to deploy it, we should make sure that the algorithm or the system is not going to give us biased outcomes. But in some instances, we notice that in some African countries, we have inadequate data protection laws because remember we said we use health-related data or population-based health data, but there are some issues when it comes to privacy and ownership. And sometimes we have existing data privacy policies and guidelines, but to enforce them into practice is also a challenge. So the absence of all these harmonized health data governance frameworks and lack of clarity around who owns the patient's data. In some countries, they are now enforcing guidelines to say the patient must own the data before the data has been given to a certain organization to do the simulation, testing, and so forth. The patient must be informed and then give a consent. So there are those gray areas on who owns the patient's data. Are they individuals? Are they the owners? Or are the hospitals or the ministries? And what is going to happen in a situation whereby we have a health ministry working with an NGO and they've signed an agreement probably for 5 years, who is going to own that particular data after the period of the contract? Is it going to be the patient? Is it going to be the ministry or the NGO? And what is going to happen if there is a potential violation of data privacy? Is the person going to be informed even though the data is anonymized? So those are some of the issues that we are currently facing when it comes to deploying or developing AI models in African context. And then another important aspect that we are also witnessing is the inclusion of local languages in cultural context. We have seen that many of the existing literature and many of the models that are using AI to analyze data and so forth, some of them, they exclude the local languages, and some of them, they also exclude indigenous knowledge or indigenous health practices. We know that in Africa, we have the traditional healers and so forth. So how best can we incorporate their knowledge and build an algorithm, an AI algorithm that will then be transformed into a model and later into a system that will also understand the traditional aspect or also incorporate indigenous knowledge? I understand that it's actually difficult to quantify or sometimes to come up with that kind of a model that understands the indigenous health practices, because there are some also issues that have to be included in developing that particular algorithm. So some of these challenges, they are actually affecting the deployment of AI-based algorithms. And then now move on to, because like I said in the previous slide, now imagine we develop a very good chatbot, and this particular chatbot exclude the cultural aspects in the chatbot. Now the chatbot has to be used by probably people living in different areas, and some of the suggestions, some of the ways that are used by the chatbot to communicate, they might have that big mismatch and then conflict with local beliefs and traditional practice that will definitely lead into chaos. So those are some of the issues that we also need to understand when you're developing these chatbots and so forth. Understand the context in which the chatbot is going to be deployed, work with the people, work with the end users and the ministry and the NGO, and incorporate individuals from those population groups. They will give you a very good insight on how to include local languages and local beliefs into an AI model. And then after that, we also have another challenge that we have is the infrastructural gap and the local AI capacity. We have witnessed that in most African countries, we have the shortage of skilled African AI developers, and now we have this emerging area where we don't have enough skilled data scientists. And the clinical AI ethicists, we are also having that. So, right, even if we develop probably experts have a degree, they go to the industry and so forth. After gaining a lot of experience, they move on to other countries and they look green pastures. So we are keeping on retraining, and we know, colleagues, that retraining someone this particular field is actually a challenge. So we are ending up now retraining a very good AI developer, very good data scientist for other countries. So how best can we probably make the environment conducive to nurture young talents and attract the talents, and then we use that talent to develop very good AI applications that will probably assist us and our healthcare professionals to improve health outcomes. And like my colleague has said in the previous slide, we have an reliable electricity supply, because for us to deploy these AI applications, I haven't seen an AI application that is using USSD technology. Most of them, they have to run on smartphones and so forth. So if you are looking at someone who's living in deep rural areas where they have experienced many constraints, it's going to be difficult again to achieve equity. So we need to keep on looking at all these digital infrastructure challenges and also lack of AI experts in the many African countries. So that's another challenge. Then I'll move on to legal and ethical. So we have issues when it comes to first, number one, to even use the data to train AI models. There are some ethical issues and some gray areas. Now, in many African countries, we have very good mobile digital health policies and so forth, which are very good. They focus more on applying different IT technologies or ICT technologies in healthcare. But now, if you look at AI models, most of the developers, they are using existing algorithms, and they simply call probably a package and then use it. And after calling a package or a library and then implement them, most of them, they don't understand what happens behind the scene. And when we are calling libraries, we're simply importing, they are hosted somewhere. So we simply import them, they analyze the data, and then they give the results. But now there's a third party involved in this developing of that particular algorithm. And that particular third party, we don't have control over what is happening in the background, because we are simply calling an algorithm using APIs. Who control the APIs and so forth? So those are some of the gray areas that are actually limiting us in implementing these AI tools in our healthcare system. So we are lacking in terms of coming up with an up-to-date ethical guidelines for AI in healthcare. And we're talking about up-to-date guidelines for AI. We are looking at, number one, the issue of transparency is also important, the issue of accountability. Let's say you've packaged a very good AI model, either it was trained using supervised learning algorithms or unsupervised learning algorithms. You have transformed it into a fully fledged package. It is now running on your device. And remember, we said some of these are using APIs. What is going to happen if there is a data breach? Who is going to be held accountable? Is it the person, a healthcare professional using that particular application or system? Or is it the institution? Or is it the ministry or the developer? Of which, if we look at that now, we are limiting ourselves, because we said these algorithms, they are hosted somewhere. We are simply importing the libraries. So we need all those cross-border initiatives now when we are developing these applications, because if we don't address that, it's going to affect us by deploying it and also developing without having trust and confidence in all those areas. So a lack of AI-specified ethical review boards. In some countries, they actually don't have. They have a general review board. If you're developing an ICT application, the basic application that works on a desktop, they will simply use the same review board when they are now reviewing an AI-based application, of which, yes, it is an application, but the technologies embedded, they're not the same. So in those ethics review board, we need experts in AI who understand the technical issues involved in the development of AI and how they compute results and come up with probably recommendations. So we are still lacking. We need to improve on that. And in some instances, we have limited standards. All right, or in some countries, we don't even have standards for AI in terms of transparent accountability and also explainability. Yes, we are seeing AI models running, giving us results, but to understand how they compute those outcomes and so forth is not clear. So if we are to have those standards, say if you are to deploy a certain AI-based application, please take us through all this and explain how the outcome was probably computed or achieved. Right, so we lack when it comes to that. And another factor, colleagues, other ethical and legal gray areas is the cross-border data flow. We have witnessed during COVID-19, different countries, they wanted certificates for vaccination certificates, and they were also using different contact tracing applications or tools. But the moment I move from country A to country B, right, and they are relying on a certain country's vaccination certificate. But if you ask ourselves, do we have any regulation in place besides the WHO guidelines when it comes to access to healthy data when someone's crossing one country to another? So we are lacking on cross-border data flow. We need to come up with the regulations and policies, and we scale them up into all African context or continent. And then we also have another issue on data sharing agreements. We have also indicated that we have our health ministries working with the different NGOs on certain projects. In some of these projects, they are being rolled out at a national level or a national scale, but the agreement probably is working for a certain period of time. What is going to happen after? Because we have witnessed that so many companies in this particular space, they are training different algorithms, and we know that access to data when you're training algorithms or AI models is actually a challenge. So it comes as in form of a grant. Then we have this particular agreement for that short space of time. It could be a 5-year grant, it could be a 10-year grant, or probably 15 years. And then we train models. Then what is going to happen right after that? In terms of accountability, in terms of transparency, right? If anything happens, what is going to happen after that? So these are some of the gray areas that we are lacking. We need to come up with that. And sometimes, yes, we work together with different NGOs through the ministries, through different health ministries, and develop different good prototypes, and they are rolled out. So we have different prototypes that are being rolled out now at national level, probably at provincial level, or regional level, and so forth, or at county level. But we are witnessing a challenge. The project or the application will simply run during that time frame of the grant. So we don't have strong long-term sustainability plans to roll out, to keep on rolling out the application right at national level, regional level, and then take it to outside Africa. So what we are experiencing now is that we have an application being piloted for that short space of time. It could be 5 years, and the application might begin giving us good results. And then life after the project plan is going to be a challenge because we don't have very good, sufficient long-term sustainability plans. So these are some of the areas that we need to address so that we don't recurring or we don't keep on piloting different prototypes for a certain period of time. And then next time we have another prototype again coming from different NGO, we pilot it, let's craft it and have a long-term sustainability plan for our different applications. And then another important area, and this is
Dr. Mbunge?
Yes.
Could we wrap up because we're running out of time and we still have another speaker, and then we'll come back to. I think you've raised a lot of interesting points, so we'll come back to more in the Q&A.
Okay, thank you so much.
Would that be fine?
Yeah, that's fine. I thought actually this is my last slide.
Okay. Why don't you just wrap up in the next minute and then let me introduce. Oh, well, okay, great. Okay, let me go to Dr. Reagon then. Cool.
Thank you.
Thank you for that. There was lots of important points raised here, and I think that will generate a lot of questions in the Q&A. So I encourage the participants to please post your question in the Q&A, and we will get to them after the next speakers. It is my pleasure to introduce you to Dr. Valamar Malika Reagon, who's a public health and AI strategist at Smith Hill Global Consulting. She's an influential force in public health, bringing over 25 years of experience across healthcare management, global public health, and health system strengthening. A passionate advocate for global health equity, Dr. Reagon's work has impacted communities globally, leading to improved programmatic and health outcomes and stronger health system. She holds a doctorate in public health and has built distinguished career driving innovative solutions for complex public health challenges. Dr. Reagon has spearheaded the development of strategic information systems and processes for US-funded programs, particularly in HIV, TB, and other infectious diseases. Dynamic leadership has transformed monitoring and evaluation frameworks, health equity measurement, and data quality initiatives that continue to shape the future of public health globally. She holds degrees from Northwestern University, Tulane University, and Georgia Southern University. We're not sorry, when not leading global health initiatives, she enjoys exploring Texas. Why only Texas? Reading and soaking in the vibrant cultures of New Orleans, which is an amazing city. Always seeking new adventures, Dr. Reagon is excited to engage with audiences who are eager to drive change and innovation in public health. Over to you, Dr. Reagon.
Thank you so much. New Orleans is home for me, so Texas is large enough to explore. It takes a lot of time to get across Texas. So thank you for having me here today. I'm very excited about this. It's very early in the morning for us over here in Texas. And I'm going to get to the points of, you've heard why equity matters and how AI can bridge divides. My role is to somehow I got muted. Okay, my role is to take us a step further. And what does it mean for Africa not to just use AI, but to lead in shaping it? That's where I'll focus on ownership, innovation, and setting the global standard. Next slide, please. Others have noted risks, biases, inequities, technical limits, and that's really where my bread and butter is. I focus on governance and ethics in artificial intelligence. But I want to sharpen the focus here. Based on lessons from the past and principles for the future, these 4 guardrails are Africa's non-negotiables. If AI breaks them, it breaks the people. If Africa holds them, then Africa leads. Tech colonization, we don't talk about that enough. First, the risk we know too well is tech colonization. That's when outsiders control digital infrastructure, data, and decisions, extracting value while African countries carry the risk. And we've seen this throughout the decades through different initiatives and programs in the form of aid. Picture a donor-funded pilot that looks promising. We've all experienced this, and I've been on the donor side, so I understand what it looks like. And so the donor-funded pilot looks good on paper, but the servers sit outside the country that it's serving or the continent. Or a contract that ties the ministry to tools or a flashy app, it can't afford to exit. The technology may look shiny, but African countries carry the risk while outsiders profit. And I'll keep repeating that because we don't want to repeat history. We cannot let AI replicate the extractive patterns of past health initiatives. Ownership is not just an economic choice. Ownership is a health intervention. Without it, you don't control the future of care in your own communities. And that's a very big aspect. And so when we think of colonization, we need to look at tech colonization. And I do other lectures on how incorporating indigenous languages and mother tongue languages could lead to tech colonization, and how excluding some of those languages may be a protective factor. But that's a whole other lecture. And when we talk about ethical AI, too often ethics is treated as compliance. They're usually check boxes and policies. In Africa, ethics is Ubuntu, it's Harambe, it's collective well-being in practice. Ethical AI means an algorithm that does speak Zulu, Yoruba, Kiswahili, Wolof, Amharic, not just English, French, or Portuguese, right? An AI that respects oral traditions as knowledge with protective factors built in. It means protecting the oral traditions as data, not dismissing them as noise. And it means reducing the burden on nurses already stretched thin, not adding one more login screen to their day. So we don't want to add additional clicks and forms. So ethics here is not abstract. It's making sure the technology honors the people it claims to serve, and ethical AI in Africa must protect the culture and lighten the burden. And lighten the burden is a very key aspect. It's not replace a position, it's lighten the burden that someone already has. And if you're paying attention to the news these days, the AI systems that are being deployed are sometimes not being adopted, as we saw with electronic health records. It's actually increasing a workload instead of taking it away. And so keep that in mind when you're talking about ethical frameworks and ethics going forward. And governance, this is my baby. This is what I live and die on. Governance is without rules, even the best intentions drift. Governance is the guardrail. Guardrails are what make technology trustworthy, right? And in South Africa, you have, I call it POPIA. That might not be the correct way to say it. It's POPIA. It's procurement rules that stop predatory contracts. Often people don't think about the procurement rules and they get themselves into contracts because they're thinking about the technology rules, but you need to think about the procurement rules as well. It's community review boards. When we talk about stakeholder engagement, the community should be involved in anything governance related, right? And so you want them to ask the hard questions. Governance is who decides, who benefits, and when it fails, who answers. When funding stops, does everything stop? Where does the data reside? We saw what just happened with USAID. There's a lot of questions of what happened to all of the samples that were collected for HIV laboratories? Where are they sitting? What's being destroyed? Where is that data sitting? A lot of people can't answer a lot of these questions. You have to be able to build that into your governance structure immediately. And governance turns AI from a black box into something accountable, because it really makes it accountable because it forces transparency. You can audit, you can challenge it, and you can improve it. Governance is a problem within U.S. healthcare businesses and many organizations right now. Governance is not at the forefront of what everybody is doing. Everybody's playing catch up right now, and they're really trying to figure out how to move governance and really get control of things, right? This is where I say African countries can lead in this area. You can set the standard across all sectors. You have the opportunity, the capability, and the talent to say, before we go too far, let's set these guardrails in place. Sovereignty. Sovereignty is Africa's right to own and control its AI destiny. That comes down to your right to decide, to hold your data, and to keep the value created there. The decision, Africans set the priorities. Africans must choose the priorities and use cases. When you think about that, each country is different. Within countries, there are so many different dynamics. You must choose your priorities and your use cases and not allow outside forces, because they have dollars, to really sway how you move. Data. Data has to be stored, processed, and governed locally, and the dollars. The value AI generates must be reinvested in African health systems and not siphoned abroad. And as you can tell, I'm speaking a lot from coming from a global aid perspective. And so that comes, I'm still on the first slide. Can you give me 1 second? So if you lose those three, then you're not leading. You're essentially tenants in your own house. So sovereignty is the line between Africa adopting tools and Africa shaping the future. So these are the non-negotiables. And what Africa must protect before you scale AI in health is tech colonization, ethical AI, governance, and sovereignty. Without them, history repeats. Without them, African countries can set the foundation to lead. And that's where I'm going. Okay, you can go next slide. So Africa's realities are not constraints, right? They are launch pads for innovation the world needs. Instead of repeating global approaches, let's look at where Africa leads. And limited bandwidth, strict privacy laws, climate pressures, and multilingual communities, these are not barriers. They are the reason Africa is pioneering solutions others will adopt. These are where the continent is leading, and where actually we have not caught up in the United States at all. And this is where I say you are going to be the pioneer of how to deal with so many different constraints that basically other areas and other countries are ignoring. So offline and edge AI, right? You're going to start with offline and edge AI, which is born of bandwidth constraints. It has now become a global model. So a community health worker in rural Zambia opens a simple triage app. There's no signal, no problem. That happened to me when I was in the middle of Angola and I was trying to stand on a rock, or it happened when I was in Zimbabwe. And the AI runs on the phone itself, right? And it still allows the community health worker to guide her step by step. That's not the future. That's already happening today. Nigeria piloted the concept of mHealth with USSD during the Ebola response, and now they have already built on top of it. Those are two technologies that are happening right now and are using and being owned by different countries that can be sent out or shared across the world. Why Africa lead? Because bandwidth limits and device diversity force efficiency. That's a global export. When you think of what are our global exports in artificial intelligence, that right there is a global export. We can take that and we can put it in India, we can put it in Tajikistan, we can put it in rural Louisiana and rural Texas, right? So the first step that you would want to do, of course, is you pilot with any community health workers. And by the way, we have community health workers here in Texas. I just want y'all to know that. And you using voice and offline tools. And then your proof comes in your minutes saved per patient and more children seen per day, right? And so then you take that and you scale it. Let me talk about federated learning. The data stays local. Collaboration without surrendering raw data. That is very key. Collaboration without surrendering raw data. The Pan-African COVID modeling collaborations did that without sharing raw data, and it worked very well. There are hospitals in South Africa that can train a shared model to predict drug resistance while all patient data remains local. So no data leaves the hospital walls, yet the model grows smarter. This aligns with the POPIA and protects sovereignty. So you connect a handful of hospitals with shared tasks, and then your accuracy goes up, but your data never leaves the country, the hospital, or the continent. And those who have experienced PEPFAR understand why this is a sticking point. Where Africa leads is fragmented systems plus strict laws make federated methods not just attractive, but necessary. This is where each country in Africa can take a specific step to say, these are our laws and this is how we're going to follow it. And we are going to make sure that our data does not either leave the health system that we're in, the business that we're in, or our country boundaries. Now, climate and vector early warning. A lot of people don't think about how this is so important because right now, climate and vector early warning is one area where people are not paying attention to as much. If you think about Africa's climate vulnerability, it makes it urgent, right? When I was in the Congo, several times there was a lot of malaria outbreaks. When I was in Haiti, we were dealing with cholera. And then when you start moving around, think of all the countries where climate and vectors integrate and affect public health outcomes, right? And affect healthcare. And that's why I say climate vulnerability makes this urgent, and it's an area where African countries can really set the standard. West Africa cholera predictions combining rainfall and water quality can change the entire game of how we predict where and when outbreaks can occur and how we can get ahead with public health prevention. So imagine an AI model blending rainfall data, mosquito density, and clinic malaria reports. It predicts an outbreak weeks in advance, letting districts stock drugs and nets before the surge. Rwanda's drone delivery system already proved logistics can leapfrog, right? So this takes it further, predicting the crisis before it arrives. That leads to fewer stockouts, faster response times, and lives protected. So climate variability hits malaria, cholera, and heat stress hardest here. Think about how you can lead the world in this development and from an artificial intelligence perspective already with the initiatives that you all have put in place across the continent. And then when we think about multilingual and voice AI, right? And this is Ubuntu through language, right? So you have Kenya's M-Pesa plus WhatsApp chatbots now extending into maternal health reminders, right? Health doesn't only live in English, French, Portuguese, or Afrikaans. It lives in Xhosa, Wolof, Amharic, Xhosa, right? and so many other languages across a country. Now, a mother in Senegal could hear instructions in Wolof, and sorry, I was formerly married to a Senegalese Nigerian man, so Wolof comes across a lot in my family. And an elder in Ethiopia should ask questions in Amharic, right? Voice AI that speaks the diversity of languages, honors oral traditions, and expands access. With this, you have to pilot tools with 1 or 2 local dialects. And then your proof would be higher comprehension, fewer errors, more patients following treatment. This is one area where you have to be careful and set clear guardrails and protective factors that don't lend itself to stereotyping. And that's what we're seeing here in the United States when they are putting out multilingual or specific voice models for specific populations, and unfortunately, it is leading to stereotyping. And so that's causing a bit of a problem. So you want to make sure that you build with those guardrails in mind. I have a list of additional opportunities, but I'm going to briefly mention some that are timely because this is where you guys are leading. You have supply chain and demand sensing. Okay. I'm still on the first, I haven't moved to the next slide yet. You have supply chain, demand sensing, you have low-cost imaging and pathology triage, you have pharmacovigilance, sorry, I cannot talk, it's early in the morning, and counterfeit detection, which is very, very big, especially when you're talking about counterfeit drugs coming across country borders. You have workforce upskilling with AI tutors. We can see that happening. And you have sovereign benchmarks and model cards, right? And that's publishing African metrics to set the global standard. And so these aren't, you know, charity use cases or hand-me-down tech. They're Africa-first solutions. And the continent realities force Africans to design differently and better. And that's the key part, and better. There's so much innovation happening on the African continent that is not being shared at a really, really high rate, and it needs to be. You all should be dominating the space when it comes to publications, which I'll talk about on the next slide, but coming to publications and moving forward in how you get what you're doing out there. The proof is in the metrics. We've seen minutes saved, errors reduced, stockouts prevented, and lives protected. And that's leadership the world will adopt from you. Next slide, please. So I want to pause here and recognize something important. Too often, global AI is described as if Africa is simply a consumer of technology, but when you look closely, Africa is not behind. It's charting a different path, one that in many ways the world could learn from. And this slide shows the contrast that I've observed. While the world assumes cloud, English, and vendor standards, Africa is writing a different playbook. And they're writing an offline first, multilingual first, sovereign by design. This isn't catch up. This is leadership, and it needs to be shared with everyone, right? And when you think about the different areas of the global default for centralized versus decentralized, right? Global AI has relied on massive centralized data sets, often pulled into big silos. The Africa-led pattern is, what I've seen in Africa-led projects is a different mindset. It's decentralized, it's efficient, and it has privacy-preserving approaches. These aren't compromises, they're forward-looking designs. Right now, you are seeing the shift in the conversation to small language models, right, versus the large language models. You all have been ahead of this. Way ahead of this. And so it's very interesting because you all have forward-looking designs, and I think that needs to be shared with everyone. The other thing is the English first versus the multilingual voice, right? The global default has always been most AI is an English first, app heavy, and often excludes people who don't live online. The Africa-led pattern is across the continent. I see that AI speaks I see AI that speaks in learning the diversity of languages spoken in different countries. So it's voice first, multilingual, USSD first, because rural health lives in these languages. That's leadership. Then you have the cloud only versus edge offline. So the global default is, the global assumption is you're always online, always in the cloud. Well, the Africa-led pattern that I've seen is the edge and offline by default. That's resilience, and frankly, it's the model the world increasingly needs in crises, right? When we're always thinking, what happens if you can't reach the cloud? What happens? Who owns the data in the cloud? Where is the data in the cloud residing? Too often when I ask that question to several different companies, they say, oh, it resides in the United States. I was like, that doesn't give me any indication of where this is residing, and you just gave me a very blanket level answer, and no one ever gets back to me after they say they will. The difference is you all have already come up with the offline by default, and that is going to be key when we talk about AI moving forward in the future at a very rapid pace. And then when we talk about vendor benchmarks versus sovereign benchmarks. So the global default has been benchmarks are too often defined by large vendors telling us what good enough looks like, right? But the Africa-led pattern is Africa is building its own sovereign benchmarks and model cards by different countries. And that's not just technical, it's sovereignty in practice. It's setting the standards instead of being tested by someone else's yardstick. And so when I say Africa is leading, this is what I mean. These aren't gaps to close, these are strengths to amplify. And the global AI community has a lot to learn here. And I stand with you in making sure these patterns are recognized, resourced, and scaled, because this is very important for you all to really put out there exactly how you're doing this, because it's not just what helps that continent, it will help every continent around the world who struggles to provide healthcare in an adequate and equitable way. Next slide, please. So I've spoken about the opportunities and guardrails, but I want to leave you with clarity, because closing a session like this should not just end with reflection, it should end with action. And this last slide is not me prescribing from the outside. It's me affirming what I've seen Africa already doing. And it's inviting everyone to claim it more boldly. The direction is simple. Africa must just not adopt AI, it must define it, and the world will follow. So what does Africa do next, right? And this is, Africa is a continent, and so what we want to make sure is that African countries don't follow. We want to make sure Africa is the standard setting, and we want you to define ethical AI for the world, because you all are at the precipice of really controlling a lot in the global market. Don't know, the global South is really moving in a way, and with focus on the continent right now, you really can set the standards and the guardrails for ethical AI. And so sovereignty first is big. Every AI contract, every deployment must protect Africa's right to decide, to hold its data, and keep the value it generates. Ownership isn't a detail. Ownership is a health intervention, and I stand by that. The second is publish to lead. Publish your results, even the failures. Each open brief, each African journal article makes Africa the benchmark and the reference point, and not just the test bed. So let the world measure by your standards and not the other way around. And then third is innovation with integrity. And innovation must have integrity. If a tool doesn't speak African languages, respect your cultures, strengthen communities, gather key stakeholder input before design or development, or save time for the nurses or the doctors, then it isn't innovation. You need to reject it. Demand the ones that do and build the ones that do. So if earlier sessions asked whether AI can bridge Africa's divide, my answer is yes, but only if African countries lead. Sovereignty first, publish to lead, innovation with integrity. That's how Africa defines its future, and not wait for it. And so thank you for allowing me to share these reflections with you. This is like 15 minutes of very large multi-seminar series.
Thank you so much.
So I just wanted to give you a little bit of it, but the real power is in what comes next, in the choices that Africa's leaders, innovators, and communities make together. So thank you.
Thank you so much. I think, we've heard lots of great nuggets here. There's something that you said that, really resonates with me. We don't want to repeat history. We must lead and be shaping AI in Africa. So with that, let me start off with, there are a couple of questions in the Q&A. Let me first start off with a question from me first, and then I'm going to read out some of the questions in the Q&A. So very shortly, maybe one of you could answer this, just because we have lots of different questions and we are running out of time. There are various organizations. There's government, there is NGOs, NPOs, clinics, universities, etc. How do we get people to partner or institutions to partner to advance AI in Africa? One person, whoever wants to speak first out of the panelists.
Thank you so much, Prof, for that question. So I'll just speak to it briefly. So, yes, so as you've rightfully mentioned, there are multiple partners and multiple players that need to come together. And I think what is needed is a strategic, collaborative, and also to borrow from Val's presentation, a value-driven approach. I think that is what we need to be looking at. We need to clearly define what exactly we are looking to achieve. In our context now, we've been speaking about healthcare, but there are other sectors as well: education, agriculture, job creation, and many others. And then after we make that definition very clear, we then look at why is AI critical for Africa's development, and how will each of these partners benefit, be it socially, financially, or what output are each of these players looking to have. And then I think there's need to be a deliberate effort to identify who the right stakeholders are. I think that's also very important, because we mentioned startups in our presentation, right? They play a very important part, and they need to be to have a seat on the table next to governments, policymakers, and NGOs and others. And I think fostering these collaborative platforms and consortiums, I personally lead several community of practice groups that regularly meet to discuss these opportunities. I think that's also going to be very important. And then finally, would need to have pilot projects that are able to demonstrate real impact. I think that's also very important in managing the communication across the different partners. Over.
Thank you, Dr. Tafadzwa. So let me get to the next question, and because Dr. Tafadzwa spoke here, I'm going to choose one of the other two speakers to perhaps answer this. There was a question on bias, and perhaps Dr. Reagon, you could answer this quite quickly. And I'm going to read it to you. It's on algorithmic justice. I just think bias is not neutral. It's a political and ethical failure. So how do we embed algorithmic accountability in the African AI health system, where developers, governments, and funders are jointly liable for inequitable outcomes, rather than treating bias as an unavoidable technical limitation? I think that's a long answer, but let's hear the
very loaded
short
question,
version of that.
Considering humans have biases and humans are building the algorithms, right? So you don't know what you don't know until someone points it out to you. And so going back to community of practices, when you're talking about counteracting biases, you have to look within first, right? And you have to allow people to call other people out on their biases in the system. So I spend a lot of time training my ChatGPT and Claude not to be biased, right? It takes a lot of time, and I correct it in real time. You actually have to have committees and people, and this is where I say students are very, very good at this, where you can have students go in and correct the biases in large language models or small language models as exercises, right? And help them identify those biases. Baking that into a system requires more diversity at the table originally when it's being created, and allowing people to call out the biases. And we're struggling with that. Like we are really, really struggling with that. But that also leads to adding context in. But bias, because it's human nature to be biased, until it becomes sentient, AI is going to have the biases that we have. But we can build different approaches to counteract the biases, and have community groups engage in helping those large language models counteract the biases. But you have to probe, and you have to make sure the guardrails are set up appropriately and that biases don't come across as political. That's a big thing that we're seeing right now. ChatGPT has changed where it used to allow you to correct the biases from political stance, and now it doesn't. So you have to make sure that you build that in. But that's a good, students could benefit from doing that and really learning from it.
Thank you.
That's the shortest answer I can give to a complicated question.
Thank you for that. That question was from Blaise. I just wanted to recognize Blaise. We have a question from Mr. Manuel. And let me ask this to Professor Mbunge. How can AI be used to leverage equity in access when the scales of power are favoring Western countries when it comes to data storage and access? Otherwise, the gap in funding for health system is set to grow wider. So we are seeing that, right? The infrastructure exists, in the global north, and the power is with them. So over there. So how do we ensure equity in access?
Okay, thank you so much. It's a very good question. So the best way to move forward is to sit down, like some of my colleagues have highlighted that, and try by all means to understand what do we really want to achieve. Because to answer that, first, number one, we need to invest in data sovereignty. How best can we build regional data centers in Africa? So to do that, it requires a lot of funding and investment. So once we build those data centers, we are slowly leveraging ourselves from such kind of situation. And then number two, once we have those things, we need to develop AI frameworks and standards and guidelines, which will then regulate how data is going to flow, how AI model is going to be trained using data from data centers. Otherwise, we will continue talking about this in the next 10 years without proper engagements, without investing in this. To be difficult for us to realize that.
Great, thank you. So there's a lot more questions, and we've run out of time. So I'm going to ask each of you in 1 minute, tell us what you think is the biggest takeaway that we should take from your talk, right? Because all of you gave such great, amazing, number of points, right? But let's summarize it for 1 minute, each of you. And also, so if we want to partner with you directly, how could we do that? I think because partnership is in Africa is what we need. We have expertise that lies across the continent. We have, and we want to leverage those expertise and the infrastructure across the continent to benefit the continent. So, Professor Dzinamarira, I'm going to give you the first chance in 1 minute. Sorry for the pressure.
Thank you, Prof. So I think a key takeaway for me is there is great opportunity in AI for inclusive healthcare management in Africa. The opportunity is there. We need to seize it, and we need to seize it right. That would be the takeaway for me. In terms of opportunities to partner, I am affiliated, as I mentioned earlier, with the Africa Center. I sit in the Africa Center as extraordinary staff. So we are welcome to have discussions on how to further the cause of AI in inclusive healthcare management. I'm also affiliated with 𝗂𝗵𝗁 at Columbia University. So there are avenues for collaboration there as well, and I can be reached as well. Thank you for that.
Thank you. Thanks. Professor Mbunge.
Okay, thank you so much. Thank you so much. So, right, achieving equity is a daunting task that requires a collective effort from different key stakeholders and players. So I just want to say to everyone listening, let's work together. If you're an expert, if you're a developer, if you're a healthcare professional, if you're a policymaker, let's work together and join hands, and we might achieve something. And then in terms of partnership, like I said, we can partner in developing different AI models, and we can do this together. And my contact information is available online. I'm currently working at UJ. So we can work together on different projects, especially on AI, and applying these models in the healthcare systems. That's all I can say.
Great, thank you. So I'm going to give you a chance, Dr. Reagon, just before I say that, both of you who have just summarized in a minute, both work at universities. I work at a university, interested in health, interested in AI, the School for Data Science, etc. But, what is missing is the network and the link to bring people together. So, for example, I've seen the great works that you've done in academia, and yet there isn't a forum that's brought us together until today. So I think we do need to create these forums to bring all these people together who could create magic once they start talking to each other. Dr. Reagon, over to you. What's the big takeaway? I know it's going to be very hard to summarize in 1 minute because there's so much.
But I will want to say about the forums, I attend the World AI Summit, right? And that's very big. The next one is in Amsterdam, I think in a couple of weeks, but I'm going to Doha in December. And that's where ethical AI and all of that lives. So just, I can send you guys information. And I'm actively seeking to become part of a university setting because I think the application and academia need to come together. So my final close is we've seen how AI can widen the divides, right? When others control the tools, right? But Africa has a choice, and that choice is to lead. And that's to lead by demanding sovereignty, deciding how the data is used, where it's stored, and who it benefits from. And to lead by setting the benchmarks, publishing openly, defining what ethical, inclusive AI looks like, and refusing to be measured by standards that ignore the realities across the different countries. And it's to lead by innovating on its own terms with tools that reduce burdens, speak the languages in the different countries, and prove that necessity breeds world-class ingenuity. And I think that's something that really the continent can stand on. You're breeding world-class ingenuity. And this is not a future of Africa waiting for permission, right? It's Africa defining the future of AI itself. And that is the work ahead, and it really begins now. So just, I just want to tell people, don't wait for Brussels, and AI in health will not be decided by Silicon Valley or Brussels, right? It's defined right here. It's defined right there. Sorry, I was supposed to be in South Africa this week, but it's defined right there in Africa, right? And so just keep that in mind, that it's defined right there. And I'm going to leave you guys with that.
Thank you so much. Thanks to all the presenters. Thanks to all the participants. Apologies to many of the participants who had asked great questions. Apologies especially to Njeka, who had asked 3 or 4 questions, and we don't have time to get to all the questions. Let me just summarize. We started off with a great introduction to AI, machine learning, etc. And Professor Dzinamarira set the context. Then Professor Mbunge talked about various use cases that are already happening in Africa, where there's innovation in Africa solving really big problems. And then finally, Dr. Reagon talked about ethics, governance, data sovereignty. Most importantly, let me tell you what I take away, that we must lead and shape AI in Africa because we cannot be data colonized through AI or data on the future. We have the opportunity to create the future for ourselves because the future is here. And we have the people, we have the capacity, we can do it right here. So I'm going to close it off with that. Thank you so much. Thanks once again to the participants. Thanks once again to the great speakers for your time. Good afternoon, everyone. Thank you. Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Bye.
Bye.